which is wrong. And some people say, okay, let me freeze your prostate, and then you will not have erection problem. That's not the truth. The data doesn't show that. Every effective prostate cancer treatment will have the possibility of erectile dysfunction. If you see there's a prostate cancer treatment that has zero probability of causing erectile dysfunction, it's not any good. So it's better to do nothing. That's what I tell them. There's something called high food, there's this, there's that. There's no morbidity from them, but they're not very effective. So if you have to decide what you want. So I tell patients who want non-effective treatment, have nothing. Why waste the money? Stay like that. Have the prostate cancer grow. Keep your erection, my friend. Next slide. Complications of prostatectomy is not only erectile dysfunction. The other one is urinary incontinence. But they're not that worried about that. Okay, well, that can be done. Take some medication or something, use a little diaper. But they don't realize sometimes the incontinence is so bad, who wants to have sex with them? I mean, they're in diapers. No, I mean, they're even, sometimes they're conscious. I can't do anything. It's leaking like a sieve. So they're like, that has to be fixed, which is where I come in. Next slide. Back slide. Some of them develop scar tissue or of failure. These are the complications of prostatectomy. Next slide. No, now we're getting to the erectile dysfunction, okay? So I use the prostate cancer to talk about ED, but the same thing about ED for men who don't have prostate cancer. Most men who have erectile dysfunction don't have prostate cancer, never had surgery, right? Because erectile dysfunction is, in most cases, it's a vascular disease. It's same as coronary artery disease or arterial insufficiency of the lower extremity. It's a vasculopathy. Erectile dysfunction is a vascular disease. In the case of radical prostatectomy, it's an acute nerve injury of the erectile nerves, okay? The penile nerves that innervate the arteries that cause the erection, okay? So they try to spare them doing surgery, but sometimes it's not possible to do that, so they develop erectile. But most men who have erectile dysfunction are vasculopathies because of hypertension, because of diabetes. All the risk factors of vascular disease are the same risk factors for erectile dysfunction. So I tell patients, if you want to know a man who has some risk or who are a vasculopath, ask them if they have ED. A man who develops erectile dysfunction that is severe, if you look carefully, the majority of them have vasculopathy problem or at risk of significant cardiovascular events, such as MI or stroke or other vascular. Extremely important. So, in Creole, we can say, garçon qui a problème bon, c'est garçon qui a fait réclame pour problème cardiovasculaire. So that's how you have to look at them. It's something very serious. So the wives, some of them say, oh, t'as fait trop, il est pour le fini. C'est pas tant que son crayon que dit. It's not the way it works. It's not because you've used it too much, like a pen or a pencil. You've written so much, now you ran out of ink. It's not what it is. It is that you develop a problem because the only reason the penis gets erect, gets longer, gets larger, the only reason is because the spongiosal tissue gets filled with blood. No blood goes in the spongiosal tissue, no erection. A lot of blood goes into the spongiosal tissue, good erection. That's why the young man who's 20 has no vascular problem, has healthy spongiosal tissue, there's a solid, rock-hard, warm erection. No problem. It's as simple as that. It's a vascular structure. You have to think about the penis as a complex vascular structure. That's all it is, not that complicated. So because of that, all the treatments are based on blood vessel physiology that we know with other blood vessels. Everything that responds in the other blood vessels respond in the spongiosal tissue. Because the spongiosal tissue of the penis is a sophisticated blood vessel. That's how you have to look at it. So, the medications, when they don't work, and we'll talk about the medications. One of the first line are the medications. Next slide. No, next. This slide was out of sequence. But let's go back to it, because I'm not going to talk about prostate anymore, because now you guys are interested in the direction part. Next slide. So, the vasoactive agents, they are used when the medications don't work. The Cialis, the Viagra, the Levitras, when they don't work. So usually the next step in patients who want more therapy is to inject vasoactive substances. And these are the 4 main vasoactive substances that are injected directly in the penis. The way it works is every single time you're going to have sexual activity, remember, you're going to have to inject a predetermined amount of vasoactive substances in the corpora of the penis. Some patients think, okay, vin pour piquer aí donc. What c'est qui vin pour? Oh, bye, on met le pigeon. So they think you just stick it once, they're cured. So now they're good to go. I'm like, no, it's not the way it works. It's every single time you're going to have sex. They're like, oh, chaque fois mal fait sexe, on pique en balade. So, papaverine, right? Pentolamine is basically a vasodilatory agent. Papaverine really increase cyclic AMP and cyclic GMP, and these increase the calibers, causes smooth muscle relaxation, as you know in physiology, in muscle physiology, and that causes dilation. So if you use one agent, they call it a bimix. You call it 2-agent bimix, and 3-agent trimix. The most commonly used is trimix. And trimix usually is a combination of papaverine, pentolamine, and prostadil, which is a prostaglandin E1. So the prostaglandin E1 itself works quite well, and it's prescribed as Eject or Edex. You've heard of Caverjet. Edex you can inject directly in the penis. The issue with this therapy is it can be painful, because as you know, the prostaglandins can be painful, so it can give you a painful erection, and some patients develop a hematoma as you inject the penis. Some of them are on anticoagulation anyway, because they have vascular problems. They had a stroke, they had this, and if you inject, they can develop, if they're on blood thinners, can develop a hematoma, and also some patients can develop priapism. If you inject too much, you have an erection that's more than 4 hours, that's painful, that's a big problem. If you have a priapism that lasted more than 4 hours and goes untreated, you develop permanent erectile dysfunction for the rest of your life. Because you develop what is called fibrosis of the corpora. All the tissues of the corpora, they become fibrosed, scarred. It makes it extremely difficult to later to put a penile implant if you opt to have that. So obviously after a priapism, you will never have erection again if it goes untreated for, let's say, 24 hours or so. Next slide. So next slide. Next. This is a case of urinary incontinence. This was one of my patients. That's how you try to treat it. This man is not going to have sex anytime soon. So you have to treat the incontinence first, and typically I put an artificial urinary sphincter. Next slide. So the artificial urinary sphincter, next slide, is a device that has 3 components. Something that around the urethra looks like a blood pressure cuff, the round structure that's around the urethra here. It compresses the urethra so the urine doesn't leak. So it's possible to cure 95% of cases of urinary incontinence by implanting an artificial urinary sphincter. You know, that's a big part of my practice because very few reconstructive urologists implant that sphincter, the artificial sphincter. I get referred a lot of cases from other urologists and other people in the community. So there is treatment for this man, backslide, back. So this man who's trying to leak all the time in gloves that he tied with a rope, next slide, can have this device, and that will cure his incontinence. And most of these men, once they become dry, what do you think they want? They want a penile implant so they can have sex. Next slide. Next slide. Okay, so the penis, the information comes from the brain. Okay, the neural stimulation travels from the brain to the spinal cord, to the nerves, the arteries, and that causes blood flow from the penis, brings it from the flaccid state to the erect state. Next slide. So you gotta wake up the structure. It's a jump start. And I tell my patients there are 4 on the menu. It's like you go to a restaurant that there are only 4 dishes. 1, pills. 2, penile injection, we talked about it. 3 is the vacuum erection device. I didn't talk about it, but you put your penis in like something that looks like a container, like a bottle, and then you pump it up with a vacuum, and then blood flows, and then you put a rubber band, a round rubber band at the base of the penis to hold the blood. Very romantic. So a lot of these men describe a cold erection because the rubber band makes the penis cold. So the partner feels a very cold penetration. But although it could be hard, and a lot of these men have pain because the rubber band is very painful. But some men, tolerate it. But that's 3rd choice. The 4th choice is the implant of the penile prosthesis. The implant of the penile prosthesis, unfortunately, I don't have a lot of time to talk about it, but there's a lot of misconceptions about the penile implant. But it is a very acceptable, safe way to treat refractory erectile dysfunction in the hands of experts who know how to do it. And that's a big part of my practice because I'm essentially a prostatic urologist. I do a lot of prosthesis. Not only the artificial sphincter, but the penile implants and other prosthetics that are used in urology. So if you understand the concepts, the techniques of prostatic surgery in urology, your success rates are higher and your complication rates are lower. So in expert hands, the success rate of the implant of the penile prosthesis is 98%. So a lot of people say, okay, the implant of a penile prosthesis, it's a huge operation. It's a complex thing. It has so many different problems. It's not natural because people don't know exactly what it is. But in reality, most men, many of my patients have a penile implant. I don't recommend it, but their partners don't even know they have it. It looks so natural. Let me give you 2 stories. I have a man who came to me. He's like, my wife, I spoke to her about having a penile prosthesis. The wife said, absolutely not. He says, I tried everything with you. Nothing worked. So I'm having it done, and she will not know. He's an engineer. He said he went for a conference about building houses for 2 weeks, but he actually came and had a penile implant. And then he went out. He said he still had the conference, but he was here in Florida. I don't know the details, but that's why he explained to me. But he went back home, and they started healing, and the wife didn't even notice that. And then the wife had recently paid a gym for him to go to the gym, thinking that will help his cardio, which is a good move. And then he had sex for the first time with the wife after the penile implant. The wife said, what happened? He's like, remember I'm going to the gym? She was like, the gym did that? He's like, absolutely. The wife said, I'm going to pay a year membership for you every year. True story. She's like, I have never seen anything like that. He's like, you became a young man. She didn't know. So a lot of people say, oh, can they tell if I have it? Even the wife could tell he had it done. Some people say, oh, will I feel it? Will the man feel it? Absolutely. You'll feel it as if it's normal. That's what they tell me. I mean, I don't have any personal experience. But all the men tell me that. They said it's as if natural. Some people say, oh, are you going to ejaculate? Absolutely. If you used to ejaculate before, you're going to ejaculate with it. Some people say, will I be able to have children? Absolutely. You're going to be able to have children if you have normal fertility. And the thing about it is you don't have to worry if it's going to work or not. It's always available. It's always with you whenever you need it.
That's true.
The other thing about it, it takes seconds for it to be active because, next slide, let's get the last slide so people can see what I'm talking about. Next, we'll go fast. These are the arteries. Next. Just move fast because I promise. We're going to skip. We talked about the sycophancy. We talked about these already. So let's talk about the serious stuff. We all know about the men. Okay, this is the vacuum thing. You put your penis inside the bottle, and then you pump it up, and then that rubber band at the base makes the penis cold. Next slide. That's the penile injection. We talk about it. Each time you're going to have sex, you're going to inject your penis. For some men, it works. So I prescribe it. The transurethral one, it doesn't work. So it's of historical significance. Next slide. This is the penile implant. The penile implant, there are those cylindrical rods are placed inside the penis. You pump it up. It gets hard. You press a release button. It deflates. So it mimics the normal erection. And the erection is sometimes more rigid than what you had when you were 20 years old. So I placed one in a man who was 50 years old. He's so happy with it. He says, I'm like, are you happy with it? He said, yeah, I have one remorse. I'm like, what's your remorse? He says, I regret I didn't have it when I was 30. I'm like, 30? You needed one when you were 30? He said, I didn't need it, but it's better. What I'm doing now, I couldn't do it when I was 30. He says, I lost 20 years of my life. He says, imagine whenever I'm going to go for a sexual activity, I never have doubt of exactly what my performance is going to be. See, my heart never beats, skip a beat. I never have doubt, no question asked. So, next slide. There are several types. This one is a malleable one. It stays hard all the time. Most patients don't like it because you don't conceal it as well, but it's called a malleable penile prosthesis. Next slide. The second type is a two-piece. It's a little bit less natural. It's easy to place. Typically, surgeons who don't have a lot of experience in penile implant like to use this device. And some people who have a lot of abdominal surgery, some people used to like to use it in them because you don't want to get into the abdomen to put the reservoir. Next slide. But the gold standard, next slide, is this one, the three-piece. As you can see, there's a reservoir up there, just a little irregular fashion above the cervixes. So sometimes some surgeons get intimidated by putting it. That's why some surgeons don't put the three-piece. But I personally like the three-piece because it gives you the more rigid erection and the more natural erection, the better deflation. Next slide. And this is what it looks like. Next slide. And this is a true patient line. You can see in the flaccid state, if you see a penis like that, you probably would not think it has a device in it. And he's starting to pump it up, and this is what it looks like. So, next slide. and everybody's happy. So the thing is, the all therapy is the first line. If you're responding to it, you don't have a lot of side effects, it's excellent. I tell patients, don't go have surgery if you're responding to oral therapy. And the oral therapy, all the medications work the same way. They increase cyclic AMP, cyclic GMP level, and that causes relaxation to nitric oxide, relaxation of the endothelial cells. They prevent phosphodiesterase inhibition. Therefore, you have more cyclic GMP, cause more vasodilation. They all work the same way. There's never been any trial that says Viagra is better than Cialis, Cialis is better than Viagra. Different patients respond to a different agent. The difference is Cialis has a longer half-life. When you take it, you can have sex many times instead of redosing. That's the only thing. And the Standra itself, the onset to start working is 15 minutes rather than half an hour. And please tell your patients, if they're gonna take the phosphodiesterase inhibitors, don't take it with a full stomach because they will not absorb it very well. They might say the pill doesn't work, particularly if it's a fatty meal. So tell them to take it easy when they're gonna take those agents. Number two, tell them to take it about 1 hour before sexual activity. A lot of men say it doesn't work. It's because of 3 reasons. Number one, they take it with a full stomach of steak and grill. Number two, they take it and in 5 minutes they want to go have sex. Well, it didn't already get into the bloodstream, so it didn't work. And number three, they didn't get into the romance of it. For the medication to work, there must be some CNS stimulation with nitric oxide. So I tell my patients, you're gonna take the pill, but your partner is gonna help you make the pill effective for you. So it's a team effort. So I tell my patients, if you take the pill and you go watch a war movie or a horror movie, you're not gonna get an erection. Because there's no stimulation. If you take the pill, you get into a fight with your wife or your partner, you're not going to get an erection. So I have some of my patients who say they want to test it because their wife is in Haiti. So they want to take it and sit down and see what happens. I'm like, nothing is going to happen. What did you do to have an erection? He said, I took it, I sat down, I watched TV. Well, what did you watch? I was watching the news. Well, it's not going to work. So you must educate your patients. You must educate your patient what will allow the medication to work. For it to work, you must take it with a stomach that's not too full. You must wait enough time, and you must have stimulation going on. Okay? Whereas versus the penile implant, you can eat as much as you want. You can have no stimulation, you will still have an erection as long as you press the button. So if you don't want stimulation, no matter what happens, then it's the penile. But anyway, I think I ran a little bit out of time. I did the best I could to talk about prostate and erection.
Yes, you did good. Yeah, thank you so much.
Dr. Gousse, I have a question.
No, I just want to know, is your study published? Because I did I had to use other methods. But when I did my research paper for my master's, I tried to do it in prostate cancer in Caribbean men. And I must tell you, there was no research data out there, especially for Caribbean men patients. So is your research published?
Yeah, thank you. That's a great question, and that's a great observation. Some of my data is published as an abstract form, but the manuscript is not out yet.
Okay.
So it hasn't been published as a manuscript, and we plan about a year from now to have this published. There are some manuscript published on the Jamaican community.
Yeah.
Yeah, I just mentioned, but there's a paucity of data, and I think it's about time that we publish the data. Because you see, there's no data in Haiti.
No.
That I know. And there are very few communities which services that many Haitian patients as we do. So very few, if any, would have the type of data that we have. We have more than 2,000, 3,000 Haitian men biopsies. So we are at the unique opportunity to present this type of data.
Yeah, I can't wait for it to be published. Thank you so much.
How do you treat priapism?
How do we treat priapism? The first, remember, it's a vasodilator that causes priapism. So you use the antidote, which is a vasoconstrictor. So we use pseudoephedrine, is my favorite. I dilute it to a small concentration, and you inject it into the corpora, and that causes vasoconstriction, and that vasoconstriction treats it. Sometimes if the priapism has been for too long, the tissues don't respond to it, you have to do what is called a shunt and aspirate the hypoxic blood from the corpora, and sometimes you have to do some other techniques, but that's how you treat it. But in most cases, if you catch the priapism early, you can give a vasoactive, vasoconstrictive agent directly into the corpora that will trigger it. Which, by the way, you only need to inject one corpora because both corporas are connected to a dorsal bridge. So the right corpora and the left corpora, they are connected. So if you inject something on the right, it's going to find its way to the left side. Yes.
I have actually two questions. One was, you said that the only part of the prostate you can reach from the rectum is
The posterior part.
posterior. So if they have cancer on the anterior, how are you getting a biopsy of that part?
Yeah, that's a very good question. Typically, you can't reach it. Although you can reach it, sometimes we do anterior biopsies in patients who have high PSA and multiple negative biopsies. We go purposely and put the needle deep and go anterior into the prostate. And you can do that with the prostate biopsy guide. You can't feel it with the finger, but the needle can reach anteriorly. The needle has a reach from posterior to anterior. That's number one. Number second, most studies have shown that anterior prostate cancers are extremely rare. It just so happened most of the prostate cancer is on the posterior part. The reason is most prostate cancer are in a zone called the peripheral zone, PZ, the peripheral zone, and the peripheral zone happens to be posterior.
Now, my other question is, you said you do reconstruction. Do you do any type of thing with these people trying to change their sex and all that?
No, I don't get involved into that surgery myself. I reconstruct after trauma from radiation or surgical for oncology stuff, but I don't get into sex change operations.
Thank you.
All right. So many good information.
Sorry,
No, you did awesome. We can hear you all day. We can hear you over and over and over again.
well, a lot of this information is on my radio shows in Creole on
Yes,
Sundays.
every Sunday.
Yeah, from 2 to 3. Yeah.
Which
Radio Mega.
That's your mega.
We've been doing this for more than 10 years, so.
Yeah.
Thank you for all you do for the community. For talking on the radio, giving great information to the community. And thank you for all you do for the patients too in the office. Some patients come to where I work, whether the PSA is okay, I need to see Dr. Gousse. I need a referral.
Everybody wants to see him.
Yes, so I can see why you give them good information and they will it. And we're hoping that the relationship with Hannah and you will go
Definitely.
to the next level, and
Absolutely.
also the Doctors Association.
Yes.
And so together we can do better things,
Yes.
greater things for the community. This is from Hannah. This is a certificate of appreciation presented to you, Dr. Angelo Gousse, for your exceptional contribution to Hannah of Florida during Men's Health Awareness Month General Membership Meeting and educational presentation on prostate cancer, and the best one, All of them are good. Erectile dysfunction.
Amen.
Thank you very much.
Thank you. Very good.
Yes,
I'll
yes.
post it on
Thank
my-